Hello, I want to welcome everyone, all the virtual attendees. My name is Dr. Amanda Ellington. I'm a general surgeon here at Lake Charles Memorial Hospital. I have a specific focus in the surgical treatment of benign breast disease and breast cancer surgery. So I hope you find today's talk very informative. There will be an opportunity at the end for you to submit questions if you're live streaming via Facebook, and we'll try to answer as many as we can at the end of the presentation. So today's talk is titled Rules of Risk, and today's presentation is going to focus on high-risk breast and genetics. So I like to start with some breast cancer facts. It's the most common cancer in women in the United States, and it is estimated that 276,000 cases of breast cancer will be diagnosed in 2020. And it is also estimated that over 40,000 deaths will occur from breast cancer. So from the year 1987 to 2007, there was a 40% reduction in breast cancer mortality. And this was due to the advent and push through of screening mammography. So mammogram is the gold standard breast cancer screening modality. It involves a 3D image termed 3D tomosynthesis, and it correctly identifies breast cancer in 87% of cases. And below you see a picture of a sample mammogram. The recommended age to start screening with a mammogram is at age 40. It is a good screening test. And when we say screening, I want to make sure we all understand what a screening test is. Screening is the ability of a test to pick up a diagnosis, in this case cancer, before symptoms develop. The benefits of mammogram are that it's inexpensive and has a low risk of radiation exposure. There are other imaging modalities to evaluate the breast, and these involve breast ultrasound and breast MRI. The main focus will be mammogram. We'll touch on MRI in a little bit. So what are the limitations of a screening mammogram? Well, 13% of cancers can be missed on screening mammography. And there are some reasons that the mammogram would not be able to pick up a cancer or an abnormality. And one of those is breast density. So anyone who's had a mammogram in the past, on your mammogram report, there's a specific comment about breast density. It typically is categorized A, B, C, D, A being least breast dense and D meaning extremely dense tissue. So the denser the breast tissue is, the harder it is for mammogram to potentially pick up an abnormality. The location of the cancer can also make the mammogram more difficult to find the cancer. Those lesions that are right behind the nipple or lateral in the breast near the underarm can be more difficult to image. And so 2D mammogram wasn't as good as the current modality of 3D tomosynthesis to pick up abnormalities. So we've come a long way in breast imaging, and 3D has shown some good benefits. This is just a sample abnormal mammogram. The circle shows a spiculated lesion in the breast on the lateral view, and this is what we're looking for and trying to find on screening mammograms. This is a busy slide. It's got a lot of information, but anyone who's had a mammogram, a BiRads classification is a standardized classification for breast imaging, and it allows for physicians and practitioners to have a common language when they're looking at breast imaging reports. So if you have a mammogram in Lake Charles or you have it in California, there's a common language. And so it's given a score, and you'll see that in the left-hand column. It's 0 to 6. 1 and 2 are a normal mammogram, and then 3 is a lesion that they see on the mammogram, but has a less than 2% chance of cancer on biopsy. A 4 or a 5 score are lesions that are suspicious enough to warrant a biopsy, and typically a tissue diagnosis is required. A 6 is a known cancer that's just getting subsequent imaging. So let's review some screening recommendations, and this is, I have it listed by society. In the top column, you'll see the name of the society, and they're abbreviated, so I'll run through those real quick. So to the left, you see the American College of Radiology, then the American College of Surgeons, American Clinical Oncology Group, American Medical Association, American Society of Breast Surgeons, the National Comprehensive Care Network, and the United States Preventative Task Force. So as you can see in the upper portion, most of these are recommending a screening mammogram to start at 40, although you do see 2 columns under ACS where 45 and then all the way to the right where age 50 is listed. And then at the bottom, they're talking about the interval, how often a woman should have a screening mammogram, and typically that's annually, once a year. So this table is data pulled from the American Cancer Society, and it's showing the incidence of breast cancer by age group. So as you can see in the top column, from the age 20 to 29, the incidence of breast cancer is quite low, 0.1%. As you go up those age categories, it's still low between 30 and 39 at 0.5% incidence. But as you get towards age 60, it jumps up to 3.5. Then age 70, it maxes out in the 70s at 4%. It actually goes down a little bit later in life in the 80s. So overall lifetime risk is 12.8%. But keep in mind that at specific points in a woman's lifetime, she is at increased risk. So you're at a higher risk at age 60 than you are necessarily at age 20. So let's focus here. If we were to follow this right column, screening mammogram at age 50, what would that look like? So this is a chart about the incidence of breast cancer by age group. You have the age range, and then in situ cases are the non-invasive breast cancers, and then you have the invasive cases. So less than 40, that represents 10,000 or over 10,000 cases. And then 40 to 49, that's an additional 35. So if every woman started a screening mammogram at age 50, 45,000 cases of breast cancer could be missed. And I personally wouldn't want to be in that 45,000. All age groups, very profound numbers. Once again, this data is 2015, so it's actually lower than what's predicted this year. Over 230,000 cases of invasive breast cancer, and then 60,000 non-invasive. So 5% of breast cancer occurs in women under the age of 40. That might sound like a low percentage, but that represents up to 13,000 cases of breast cancer. So screening with mammogram on those old charts is shown to really start no earlier than age 40. So how do we even find cancers in women under 40? So here are some facts. Breast cancer can be more difficult to diagnose in the younger population. One of the bigger reasons is that they're younger than the recommended screening age. Also, breast density once again comes into play, where younger women tend to have increased breast density, and the mammogram is not as sensitive for the ability to pick up breast lesions. Also, lack of symptoms, or thinking your symptoms are normal for your age. Lots of women under the age of 40 are still in their childbearing years, and breast pain, breast masses, you're lactating, you might think you're too young for a cancer and kind of blow off some symptoms. But let's remember that breast cancers that are found on a screening mammogram, meaning a test before symptoms, are much more likely to be early stage and curable. So how do you know if you need a mammogram before age 40? So it's very important to identify a subset of the population that needs increased screening and or earlier screening. So we do that by stratifying patients with a breast cancer risk assessment. Risk assessment is an important part of a patient's history. It is able to identify women and men with increased risk and offer screening earlier. Patients that are low risk can adhere to the general screening recommendations. So more on the risk assessment. Every woman should have a risk assessment by age 25 to 30. There's no real clear guidelines at this point for that. If you're already at age 50 and you haven't had a risk assessment, then you do it now. And we really stop the risk assessment between ages 70 and 75. The risk assessment involves no laboratory testing, no physical exam. It's essentially a series of questions. And there are several risk models that calculate the risk. Here at Lake Charles Memorial, we employ the Tyrer-Cuzick model for our calculation of risk. So this is a busy slide, and once again, we're looking at this column, the Tyrer-Cuzick model, which is a series of questions, and you can read that column there. Age, BMI, age at menarche, age at first live birth, age at menopause, the use of hormone replacement therapy, any woman who's had a previous breast biopsy that shows certain results. And then the last is very important. It's a family history focusing on breast and ovarian cancer in the family. So a lifetime risk or a score of 20% or higher on that risk assessment qualifies a patient as high risk. There are other factors besides that assessment that can make a patient high risk as well, and those are listed below. a patient that tests positive for a genetic mutation. Example would be a BRCA1 carrier, BRCA2 carrier, and there's some other genes listed there as well. Any woman with a breast biopsy showing LCIS or ADH, those two entities are diagnosed on pathology and confer the risk of developing a breast cancer. They are not cancers in and of themselves, but do increase a woman's likelihood of forming a breast cancer. So the high-risk patients are screened differently than the general population. One, they get earlier screening. Two, we add breast MRI to annual screening mammography, so these women are getting a more sensitive test to try to pick up abnormalities due to their increased risk. It is inappropriate to screen the general population with breast MRI. It is better used in a subset of patients or the high-risk patients in addition to MRI for more sensitive screening. These women are also recommended to have a clinical breast exam every 6 months compared to annually. And then there are options for medical or surgical risk reduction depending on their degree of risk. In some instances, there are interventions that can, in theory, prevent cancer or help find it at an early stage. And these are some examples. An extreme example would be a bilateral mastectomy or removal of both breasts. And this is usually reserved for an extremely high-risk patient, a BRCA1 carrier, BRCA2 carrier. In most cases, the risk is not high enough to warrant an extreme surgical risk reduction, but medical risk reduction and lifestyle modifications can help. And when I speak of medical risk reduction, I'm usually referring to a drug called tamoxifen that blocks hormones. So what if your risk is not high? You fill out your assessment, you're not 20%, you're 8%. Well, those patients with lower average risk, less than 20%, can adhere to the screening guidelines for mammogram to start at age 40 and an annual clinical breast exam. Regardless of risk, though, please remember, always tell your physician about a breast symptom, a mass, pain, etc. Regardless of your risk, those things need to be worked up. Women should repeat the assessment. I say 2 years in this, there's really no definable timeline, but if anything changes in your medical history, you underwent a breast biopsy, that assessment should be updated, or if a new diagnosis of cancer was made in the family. So how can you reduce your risk if you're high risk or just average risk? So things that you can do personally is just adhere to a healthy lifestyle. What we do know is that the sedentary and obese population do have an elevated cancer risk, and so exercising 3 times a week is important. Limiting alcohol intake to less than 1 drink per day. Over that, there is an association with an increased risk of breast cancer, and avoiding combination hormone replacement. And I say if possible, because this is a lifestyle choice. There are certain situations where a woman may need to bridge herself with hormone replacement therapy and assume that small risk of increased breast cancer. And that is a personal choice, and that is a choice and a decision that should be made with the patient and their treating physician. And then it's really important to know your family history and know your risk factors. Family history can provide us a lot of information, and so if you don't know your family history, obtaining that can be very helpful. The risk assessment also helps identify women or men who could be candidates for genetic testing based on that family history. So you might ask, well, what is genetic testing? How much does it cost? And do I really want to know if I have a mutation? What I don't know can't hurt me, right? So this is a slide, and we're just going to briefly go through this. So a mutation, or what we're testing for in the genetic testing, is just simply a change in the structure of a gene. You see a picture to the left of a normal DNA double helix, and then to the right you see a mutated strand with some abnormalities. So simply put, genetic testing is a medical test. It's done by the collection of blood or saliva, and it identifies a change in a chromosome or a gene. Now these results help determine the chance of developing a disorder, in this case we're talking about cancer, and the chance of passing it on. This is an example of a genetic mutation. These are the ones that are most widely known, BRCA1 and BRCA2. So BRCA1 is the little red bar on that chromosome. It lives on your chromosome 17 if you have it, and chromosome 13 is where BRCA2 can be found. So having a mutation in certain genes can increase one's susceptibility to breast cancer. So there's a pie chart, and over on the bottom right, you see genes listed, BRCA1, BRCA2, CHEK2, ATM. These are known genetic mutations that increase the risk of breast cancer. And remember that each gene confers its own risk. So the risk of developing breast cancer with BRCA2 is different than the risk that CHEK2 incurs. Also, many of these genes are associated with multiple cancers, so this extends far beyond breast cancer. BRCA2 can be associated with ovarian, pancreatic, and so it's not just limited to breast cancer. 10% of all breast cancer diagnosed is related to a defined genetic mutation, the genetic mutations we know. In our experience here at Lake Charles Memorial, 24% of our patients with breast cancer under the age of 40 tested positive for a mutation. So that's double the average rate. So what does that mean to us? It means that the younger patients with breast cancer are much more likely to have a genetic mutation. And it really, I think, drives the point that we should really consider genetic testing in the younger population, because it can make a difference, not just for the patient, but for family members. So here are some facts. Let's remember, testing positive for a genetic mutation does not mean that you will get cancer. It means that you are at increased risk of developing a cancer, and that risk is usually very defined depending on the gene that is tested for or that is mutated. A negative genetic test does not mean you're not at risk. It just means that you have not tested positive for the mutations we know to test for. Genetic testing has come a long way over the past 15 to 20 years. The amount of genes we test for today far exceed what we tested for 15 to 20 years ago. So in the future, we may be able to test for more genes. So a negative result does not mean you're not at risk. And remember that both the maternal and paternal family histories are significant. So true or false? If I test negative for a mutation, I'm not at risk of developing cancer. Well, that's false, because as we just noted, you can still be at risk and be negative for a mutation. True or false? Males cannot get breast cancer. Well, that is false. So male breast cancer represents 1% of all breast cancer, which is a low number, but men are not screened. So you take, for instance, and this is a sample patient of mine, a woman with breast cancer diagnosed. I tested her, and she came back as BRCA2. So we rolled out that testing to her family members, and she has a brother. The brother got tested, totally asymptomatic, test positive for BRCA2. So now he knows to go get a clinical breast exam. He can get an ultrasound or a mammogram and do things to possibly prevent him from getting a breast cancer in the future. And he would have otherwise never had a breast exam had he not had that information. So if a person tests positive for a mutation, that patient may be eligible for specific testing and or screening. So the addition of breast MRI to breast cancer screening, those patients at increased risk for colon cancer would be offered colonoscopies early. Knowing one's risk of cancer can really help guide decisions regarding testing and risk reduction strategies. Here's an example patient. This is a pretty extreme example, but I really want to drive the point home of how crucial and how important genetics can be. So a woman presented for a breast mass. She's 30, young. She had a mammogram and an ultrasound. A 2-centimeter mass was found in the right breast. So a biopsy was done, and it shows a fibroadenoma. That's a benign breast mass, not cancerous. So nothing was done further for the mass. But her physician did a risk assessment, and she found that the patient has a mother and an aunt with a history of breast cancer. Both were diagnosed under the age of 50. So with that family history, genetic testing was ordered due to that, those findings, and they identified a mutation in the BRCA2 gene. So that patient is now counseled on the risks associated with that specific mutation, and that mutation is associated with breast, ovarian, and pancreatic cancer. So the patient gets a breast MRI, gets a workup for ovarian cancer with a pelvic ultrasound, and then an MRI of the abdomen is done, and that's to evaluate the pancreas. Patient has no abdominal pain, no symptoms, but she is found to incidentally have a small nodule in the pancreas. Biopsy was done of that mass, shows early stage adenocarcinoma of the pancreas. She goes on to have resection of that pancreatic tumor for cure. So without the genetic test result, that patient would never have had the MRI of her abdomen. But because she was at increased risk and that mutation has a specific association with certain cancers, additional imaging was done that likely saved her life. So take-home points. I think every woman should have a risk assessment by age 25 or 30, and if you're older than that and under the age of 74, you should have a risk assessment now. Ask your primary care provider about it. We have a clinic that can offer the assessment for free via paper, and then we'll be developing an email portal for patients to fill it out online. The assessment can even be done over the phone. So what does Memorial have to offer? The High Risk Breast Clinic is a clinic designed to evaluate and counsel women with increased risk of breast cancer, whether that's due to a high risk assessment score, a genetic mutation. Patients are followed yearly in the clinic. Breast complaints are worked up, appropriate imaging, biopsies, etc. are ordered. Clinical breast exam done, screening and imaging ordered and followed. And then referrals and counseling for medical risk reduction and surgical risk reduction when appropriate. Our goal is to provide an easy way for women to get a risk assessment done, whether it's paper, phone, or a virtual visit. No face-to-face appointment needed. Once again, no laboratory testing for the risk assessment. The genetics clinic is a clinic very much tied into the high risk breast clinic, but separate, designed to assess patients with increased risk or chance of genetic mutations. Testing is offered, pre and post-test counseling, education. For those who test positive, detailed treatment plans for those patients are written up and sent to primary care physicians. Ellen Richardson is the nurse navigator for both the high risk and genetics clinic. Dr. Norberg and myself are the participating physicians. So the take-home message is be in charge of your care. So knowing your risk helps you make good decisions, and it also helps your physician. This is proactive medicine. Instead of waiting for cancer to develop, why not take steps and intervene before symptoms or cancer develop? Know who's high risk and take steps to potentially prevent it or find it early. Waiting around until we find it just might not be good enough. I want to thank everyone for listening, and we want to let us help you live your breast life. Questions?
Yeah, so for women who may not have a very detailed family history, whether that's because they're adopted or maybe aren't super aware of grandparents and conditions like that, at what age would you recommend that they go in and potentially get genetic testing?
So I think that any patient who is unsure of their family history or adopted, there are instances where you can simply pay out of pocket for the genetic testing, or through the clinic, those things may, with certain insurances, qualify you for the testing. So you can treat being adopted as potentially having that family history. And I do suggest, especially in the absence of any known history or early death or things like that, that you do consider testing, but discuss it with our nurse navigator, have some pre-test counseling to see what would best suit them.
Okay. Pivoting a little bit from genetics, other risk factors, does breast augmentation of any kind, whether that's a reduction or an implant or anything, does that have any impact or additional risk for developing cancer later in life?
So yes and no. So no routine, the type of breast cancer that we routinely diagnose, which is invasive ductal cancer, there is no direct link with breast implants. There is a very rare type of lymphoma that has been associated with textured implants. Its incidence is 1 in 100,000. It is different than the breast cancer we see. If a woman ever has a concern, then seeing a breast specialist and discussing those risks and an exam and review of imaging is very important. And I think it's something to know exists, but 1 in 100,000 is very uncommon. So in essence, no, but a very rare, different type could be a risk.
And one more question. So is breast cancer for women the only cancer family history that they should be concerned about?
No. In the Tyrer-Cuzick model, we are simply assessing for breast and ovarian cancer because it's a breast cancer risk assessment. But in the patients I see in my clinic, everything is important. Prostate, any cancer whether you think it's important or not, I think should be on the list and be in your history. And then you let the physician, if it's something that may be profound or sets a red flag, a referral to the genetics clinic, and they can decide what testing is appropriate for you. Genetic testing is a whole separate lecture in and of itself. And the interesting thing about it is that by family history, there are different panels that suit different patients. In this discussion, we're focusing mainly on breast and ovarian cancer because they're so closely tied into high-risk breast disease and cancer. But once again, BRCA2, a lot of the genetic mutations are associated with multiple cancers. And so it's really important. It's not limited just to breast and ovarian in any way. All cancers are important.
Awesome. Thank you.
Okay, thank you everyone for attending.